A medical test can save a life. It can also uncover a tiny abnormality that would never have caused pain, disability, or an early death. Once that finding has a name, however, it can become difficult to leave alone. Another image is ordered, then a specialist visit, then perhaps a needle, a scope, or an operation. The person who entered the clinic, feeling healthy, may spend the next 6 months living like a patient. That is why the most important question after 60 is not simply, can this test find something? Modern medicine can find a great deal. The better question is, if it finds something, is acting on that result likely to leave me healthier? Today we will examine 5 common checkups worth questioning before they are used as routine screening. The word routine matters. Screening means testing someone without a relevant symptom. A scan ordered because of chest pain, a new neurologic problem, bleeding, or a documented cognitive decline is a different decision. None of the 5 tests in this video should be rejected when there is a sound clinical reason. Stay for number 4, because the original warning about brain MRI goes too far and could keep someone from a useful evaluation. Number 2 fills a missing place in many over-testing lists, even though a major preventive guideline recommends against it in adults without symptoms. And number 1 is not governed by a birthday alone. 2 people who are both 78 can reasonably make opposite choices. Before accepting any screening test, write down 4 questions. What exact disease are we looking for? How likely am I to have it? What happens after a positive result? What changes if I decline or postpone the test? Those questions do not challenge the clinician. They reveal whether the test is connected to a decision or is simply being ordered because it is available. The chain those questions can prevent is called a cascade. Imagine a report that mentions a 3 mm spot, a small cyst, or a slightly unusual signal. The finding may be harmless, but uncertainty creates momentum. A second image may still be unclear. A biopsy can bring bleeding, infection, pain, or anesthesia. Even when the final answer is benign, the appointments, cost, worry, and recovery were real. A cascade is not proof that anyone acted carelessly. Each decision can look reasonable when viewed alone. The radiologist recommends caution. The referring clinician wants to avoid missing a rare danger. And the patient understandably wants certainty. Harm appears when no one steps back to compare the entire chain with the chance that the original finding would ever matter. Shared decision-making is the pause that lets that comparison happen. The opposite error is possible too. A normal result may offer false reassurance while missing a condition that the test was never designed to detect. A good screening program, therefore, needs more than a machine capable of seeing detail. It needs evidence that looking in a defined group, then following a defined plan, produces more benefit than harm. That standard brings us to the 5th item, the one sold with the broadest promise. At number 5 is a whole-body CT or MRI marketed directly to a healthy person with no symptoms, risk factor, or family history that points toward a particular disease. The appeal is obvious. One appointment seems to inspect everything from the head to the pelvis. The advertisement sells certainty, control, and the hope of catching every threat while it is still small. But a test that looks for everything has no clear definition of success. A small lung nodule, kidney cyst, liver lesion, spinal change, or thyroid nodule may enter the report. Some findings need follow-up. Many do not. The difficulty is deciding which is which when the scan began without a clinical question. Age makes this problem larger because normal variation accumulates. Joints show wear, discs change shape, small cysts and benign nodules become more common. The machine may be accurately describing the body, while the advertisement encourages the viewer to interpret every description as an approaching disease. Accuracy of the image and usefulness of the screening program are not the same thing. CT and MRI also carry different direct risks. CT uses ionizing radiation, and a broad scan can deliver considerably more exposure than a simple X-ray. MRI does not use ionizing radiation, but that does not make total body screening evidence-based. The American College of Radiology states that current evidence is insufficient to recommend total body MRI for people without symptoms or relevant risk factors, in part because non-specific findings can trigger unnecessary testing and expense. This warning does not apply to every scan that covers a large area. Targeted imaging can be strongly supported when the person belongs to a defined risk group. Low-dose chest CT for an eligible person with a substantial smoking history is one example. Imaging after trauma, symptoms, abnormal examination findings, or cancer treatment is diagnostic care, not the commercial screening package being questioned here. If a whole-body scan is offered, ask which diseases it has been proven to screen for in someone with your history. What percentage of findings require follow-up, and who will manage them? Ask about radiation if CT is involved, and contrast if either technology will use it. A promise to show everything is not the same as evidence that seeing everything improves health. Also, ask what the scan cannot show. A broad image does not replace blood pressure measurement, diabetes assessment, recommended vaccinations, a medication review, or the cancer screening that fits individual risk. A normal commercial scan can create the illusion of a complete checkup while leaving common and treatable risks untouched. The best preventive visit is often less dramatic because it connects several ordinary measurements to actions that have proven value. That first item is driven by too much visual information. Number 4 is more complicated because a brain image can be appropriate even though the picture alone cannot decide why someone is forgetting. Suppose a familiar name takes longer to arrive, or someone enters the kitchen and briefly forgets what they wanted. Fear can turn an ordinary lapse into a demand for a brain MRI immediately. The image may mention volume loss, white matter changes, or small vessel disease. Those words sound decisive, yet similar findings can appear in people with very different levels of thinking and independence. The mistake is not having an MRI. The mistake is expecting an MRI to replace the clinical evaluation. Memory complaints should first be described carefully. When did they begin? Are they worsening? Do they interfere with bills, medicines, driving, cooking, appointments, or navigation? Has a family member noticed a change? A brief cognitive assessment, neurologic examination, medication review, mood and sleep history, and selected laboratory tests can reveal what question the imaging needs to answer. Context can change the result of a brief cognitive test as well. Hearing difficulty, language, education, fatigue, anxiety, pain, and unfamiliar surroundings may affect performance. That is why one score should not become a label by itself. Clinicians compare the score with prior ability, daily function, collateral history, and change over time. Sometimes repeating an assessment after a reasonable interval is more informative than treating the first number as a verdict. Medication effects, depression, infection, endocrine or metabolic problems, poor sleep, hearing loss, and neurologic disease can all contribute to cognitive symptoms. Some contributors are treatable, but it is inaccurate to promise that most memory problems will reverse after one simple correction. The goal is to identify the pattern and investigate proportionately. Here is the promised correction. Current radiology guidance considers a non-contrast brain MRI usually appropriate in the initial imaging of mild cognitive impairment, and structural imaging is commonly part of a dementia workup. It can help identify strokes, tumors, fluid buildup, prior trauma, or a pattern that supports one diagnosis over another. Therefore, the safe advice is not, never scan mild memory trouble. It is, do not order or interpret the scan in isolation. The type of imaging also matters. A standard structural MRI is different from a specialized amyloid scan, functional imaging, or repeated imaging without a new question. More technology does not automatically mean more certainty. Ask what diagnosis each proposed test can support or exclude, whether the result would change treatment, and whether a simpler assessment should come first. The answer may be yes to one image and no to three others. Progressive decline, getting lost on a familiar route, difficulty managing finances, a marked personality change, seizures, an abnormal neurologic examination, a rapid change, or new problems with gait and bladder control can all strengthen the case for further evaluation. Sudden confusion over hours or days is more urgent and may signal delirium, infection, medication toxicity, stroke, or another acute illness. In that situation, waiting for a routine memory appointment may be unsafe. Number 4. Closes with a balance. An age-related phrase on a report is not a diagnosis, while a reassuring image does not cancel real functional decline. The person, the timeline, and the examination lead. The scan answers a focused question inside that larger story. At number 3, the machine is a treadmill, and the same principle applies. A cardiac stress test can be valuable when symptoms or risk make hidden ischemia a genuine concern. It is much harder to justify when the only reason is that a healthy, active person has reached a certain birthday. Consider someone preparing for a low-risk operation who can climb stairs, walk briskly, carry groceries, and perform normal activities without chest pressure or unusual breathlessness. Good functional capacity already supplies useful information. The 2024 Perioperative Cardiovascular Guideline says patients at low surgical risk, those with good functional capacity, and those undergoing low-risk procedures should not receive routine stress testing. The reason is not that stress tests are bad. It is that testing a low-probability population creates more ambiguous or false positive results. An abnormal tracing may lead to nuclear imaging, coronary CT, or invasive angiography. Those steps may be appropriate after a meaningful result, but they introduce contrast exposure, radiation, bleeding, kidney injury, vascular complications, and the possibility of a procedure that never improves the original outcome. There is another reason to avoid automatic preoperative testing. An abnormal result can delay an operation that would improve mobility, sleep, pain, or independence, even when the cardiac finding would not change management. Delay may be justified when the risk is real. It is harder to justify when the test was ordered only because an age threshold replaced an individualized surgical assessment. Age alone also does not reveal whether a screening exercise electrocardiogram will prevent a future heart attack. For asymptomatic adults at low cardiovascular risk, the United States Preventive Services Task Force recommends against screening with resting or exercise ECG. For people at higher risk, the evidence is insufficient to use it routinely as an addition to conventional risk assessment. The better starting point is the decision the test is supposed to change. Review blood pressure, cholesterol, diabetes, smoking, family history, activity, symptoms, known heart disease, and the risk of the planned surgery. If there is exertional chest discomfort, unexplained shortness of breath, declining exercise capacity, or another concerning sign, evaluation is different. A stress test may then answer a real question. Daily activity is useful evidence, but it is not a medical clearance certificate. A person may avoid exertion because of knee pain and therefore never provoke cardiac symptoms. Another may report excellent capacity despite important known heart disease. The care team combines function with the planned operation, medical history, examination, and validated risk tools. The point is to stop age from doing all the thinking, not to replace clinical judgment with a staircase. The reference video proposes a coronary calcium scan as the universal replacement. That correction is too simple. A calcium score can sometimes help a clinician and patient decide about prevention when cardiovascular risk remains uncertain, but it is another test, uses radiation, and is not a substitute for evaluating symptoms. The right alternative to an unnecessary treadmill is often not a different machine. It is a better risk conversation. Number 3 shows how a low probability result can pull someone toward the heart. Number 2 follows the same cascade toward the brain, beginning with a painless ultrasound placed on the side of the neck. Carotid ultrasound measures blood flow and can detect narrowing in the arteries that supply the brain. Because a severe narrowing can be associated with stroke, screening every older adult sounds preventive. The test is non-invasive, contains no radiation, and may be offered at a community event or as part of a bundled vascular package. Those qualities make the hidden downside easy to miss. In a population without a previous stroke, transient ischemic attack, or related neurologic symptom, clinically important carotid narrowing is uncommon. Even a fairly accurate ultrasound can therefore produce a meaningful number of false positive or uncertain results. Confirmation may lead to additional imaging. A label of severe stenosis may lead to surgery or stenting, procedures that can themselves cause stroke or death. This is a lesson in probability. When a serious condition is rare in the group being tested, many positive screens may come from people who do not have the dangerous form of that condition. Increasing the number of healthy people tested can therefore increase the number sent into confirmation and treatment without producing a matching number of prevented strokes. A technically good test can still be a poor population screen. For that reason, the United States Preventive Services Task Force recommends against screening the general adult population for asymptomatic carotid artery stenosis. The recommendation applies to people without a history of stroke, a transient ischemic attack, or neurologic signs referable to the carotid arteries. It does not apply when the test is being used to investigate symptoms or manage known disease. Stroke prevention still matters enormously. The higher value work for most asymptomatic adults is controlling blood pressure, avoiding tobacco, treating diabetes and cholesterol when indicated, staying active, and recognizing urgent symptoms. Those actions address several pathways to stroke rather than searching one artery in isolation. If a clinician recommends ultrasound for a personal reason, ask what makes the situation different from general screening. The boundary matters. Sudden weakness or numbness on one side, facial droop, difficulty speaking, sudden vision loss, severe imbalance, or another possible stroke symptom is not a screening question. It is an emergency. Call emergency services rather than scheduling a retail ultrasound. A test that is unhelpful for a well person can be essential in the right diagnostic pathway. This 5th subject also repairs the broken promise in the reference. Its title advertises 5 checkups, while its narration contains only 4. More importantly, carotid screening demonstrates the central idea cleanly. A test can be painless and capable of finding a real abnormality, yet still do more harm than good when applied to the wrong population. The final item is the most dependent on age, prior history, overall health, and personal preference. It is not colonoscopy after 75. It is routine screening colonoscopy after 75, without first asking whether continued colorectal cancer screening is still likely to benefit this individual. Colonoscopy is an effective screening tool. It can find cancer and remove precancerous polyps during the same procedure. For average risk adults, screening is strongly recommended through age 75, and several acceptable methods exist. Turning 76 does not suddenly erase the benefit. From ages 76 through 85, current guidance calls for selective, individualized screening. The decision should consider previous screening, overall health, life expectancy, preferences, and the likelihood that a positive result would lead to treatment the person would actually choose, Someone healthy who has never been screened may have more to gain than someone with repeated normal examinations and serious competing illness, even when both are the same age. Prior results are particularly important. A person whose last colonoscopy found an advanced polyp may be following a surveillance plan rather than average risk screening. Someone who has never completed any colorectal test may carry a different opportunity for benefit than a person with consistently negative results over decades. The label routine colonoscopy can hide these very different histories, so bring old reports rather than relying on memory alone. The possible harms also become more important. Bowel preparation can cause dehydration, weakness, or electrolyte problems. Sedation can affect breathing or cognition. Bleeding and perforation are uncommon, but the risk of complications rises in older groups, especially among people in their 80s. These risks do not make a needed colonoscopy reckless. They make the reason for it more important. Screening must also be separated from diagnosis. Blood in the stool, iron deficiency anemia, persistent bowel habit changes, unexplained weight loss, or concerning abdominal symptoms may require investigation regardless of the routine screening schedule. Prior polyps, inflammatory bowel disease, a hereditary syndrome, or a strong family history can also change the plan. If continued screening makes sense but colonoscopy is not the preferred first test, stool-based options may be available. A fecal immunochemical test can be performed at home, and other stool tests or visual examinations may be appropriate depending on the guideline and local access. A positive non-colonoscopy screening result still needs timely colonoscopy, so the decision should include willingness and fitness to complete that next step. The interval matters too. Colonoscopy is not an annual ritual for an average risk person with a normal examination. Stool tests have their own recommended schedules, and a missed follow-up after a positive result can erase much of the intended benefit. The choice is therefore not simply invasive versus easy. It is which complete screening strategy a person can safely and realistically finish. Diet, activity, avoiding tobacco, and maintaining a healthy weight support colorectal and overall health, but they do not substitute for indicated screening. Fiber cannot explain away bleeding, and a healthy meal cannot rule out cancer. The responsible message is not to replace colonoscopy with broccoli. It is to match the screening method and stopping decision to the likely individual benefit. Now the pattern across all 5 becomes visible. A commercial whole-body scan begins without a target. A brain MRI becomes misleading when separated from function and history. A stress test becomes low value when age replaces symptoms and risk. A carotid ultrasound can find narrowing without proving that screening improves outcomes. A screening colonoscopy becomes an individual decision after 75 rather than an automatic appointment or automatic refusal. The shared problem is not technology. It is a test without a decision pathway. Before agreeing, ask what result would count as positive, what the next step would be, what harm that step carries, and whether discovering the condition earlier has been shown to improve an outcome that matters to you. Also ask what evidence supports the test for someone with your symptoms, history, and level of function. It can help to ask for absolute numbers rather than words such as small or significant. Out of 100 people like me, how many are expected to benefit? How many will receive a false alarm? How many will need another procedure? Exact estimates are not always available, but the way the clinician explains uncertainty can reveal whether the recommendation is strong, preference-sensitive, or simply habitual. Those questions protect against overtreatment without turning caution into medical avoidance. Continue proven preventive care, such as blood pressure assessment, vaccinations, and cancer screening that fits your risk and age. Report symptoms rather than waiting for the next annual visit. A person can decline a low-value screen and still seek prompt, thorough care when something changes. If a test has already found an incidental abnormality, do not ignore the report or assume a procedure is inevitable. Ask how likely the finding is to become harmful, whether watchful waiting is reasonable, how often follow-up is needed, and what change would trigger action. A second opinion may help when the consequences are large and the benefit remains uncertain. Bring a family member or write the answers down if anxiety makes details hard to retain. Ask for the name of the guideline or risk tool being used. Confirm whether the recommendation is screening, surveillance of a known finding, or diagnosis of a symptom. Those three words can describe procedures that look identical while carrying very different reasons and benefits. The aim after 60 is not to collect perfect images. It is to preserve years of function, independence, and time that feels like your own. Sometimes a test advances that goal. Sometimes the wisest step is to pause until the purpose, pathway, and trade-offs are clear. Which of the 4 questions would be hardest for you to ask in a medical visit? You can share the question without sharing private health information. And before your next routine test, write all 4 on a card. The most useful result may come before the machine is ever turned on.